This BAP is on uterine fibroids. In this BAP, you will learn the definition of uterine fibroids, the clinical features patients present with, as well as investigations and management of the condition. Fibroids are present as benign growths of uterine muscle that occur commonly in women of reproductive age. They are found in 10 to 20% of normal women. They are also known as leiomyomas. Fibroids commonly present at 30 to 40 years of age. After menopause, fibroids tend to reduce in both size and number. The risk of malignancy into leiomyosarcomas is low at 1 in 1,000. Risk factors for fibroids include increasing age until menopause, African and Caribbean women, a family history of fibroids with a 3-fold higher risk in first-degree relatives, and obesity. There might also be an association of fibroids with low parity and infertility. Fibroids are defined by their location in the uterus, namely subserosal, which is on the peritoneal surface of the uterus, submucosal, which is under the endometrial lining of the uterine cavity, and intramural, which is within the myometrium. Microscopically, they are smooth muscle bundles. Depending on the type of myoma and their locations, symptoms and signs vary. Many patients with fibroids are asymptomatic, with incidental findings of fibroids on ultrasound scan. Common clinical features include menorrhagia and dysmenorrhea, especially in submucosal or large intramural fibroids. Sometimes, menorrhagia is severe enough to cause anemia. Pressure symptoms on the urinary and gastrointestinal tract can cause pain, urinary and bowel symptoms, bloatedness, and dyspepsia. Submucosal fibroids may result in subfertility or recurrent miscarriage by interfering with implantation. In pregnancy, degeneration of fibroids, known as rate degeneration, can occur in 10% of patients, leading to an increased risk of preterm labor and placental eruption. Diagnosis is usually confirmed by pelvic ultrasound done transvaginally or abdominally. If further information about fibroid position, size, number, and vascularity is required, MRI should be considered. Hysteroscopy will be useful to visualize submucosal fibroid. Treatment must always be tailored to a patient's symptom severity, reproductive status, and of course personal preference. Treatment can be either expectant, medical, or surgical. Expectant management is acceptable if the patient is asymptomatic and the fibroids are less than 5 cm in size. Follow-up ultrasound scans 6 months apart can be done to monitor the growth of the fibroids during reproductive age. Medical and surgical management will be further elaborated on in the next few slides. Medical management aims to relieve symptoms or decrease fibroid size. Menorrhagia can be treated with tranexamic acid, while dysmenorrhea is relieved with non-steroidal inflammatory drugs. If both menorrhagia and dysmenorrhea are present, NSAID should be the first-line treatment of choice. Fibroid size reduction can be achieved with GnRH analog. Pre-treatment 3 to 4 months before myomectomy or hysterectomy can be considered if fibroids are causing an enlarged or distorted uterus. However, GnRH analogs cause low estrogen levels, causing side effects such as menopausal symptoms and accelerated bone loss with an increased risk of osteoporosis. Hence, maximum treatment period is 6 months duration. A small study involving 5 women has shown that the Mirena intrauterine contraceptive device was effective in reducing fibroid size. However, further studies need to be conducted before it can be recommended as a treatment for this purpose. Surgery is indicated when medical management fails. The type of surgery will depend on the patient's age, parity, and desire to conserve the uterus. One can opt to remove the fibroid alone via myomectomy or removal of the whole uterus via hysterectomy. There are various approaches to each surgery. Myomectomies can be done via open surgery, laparoscopically, or hysteroscopically. Hysterectomies can be performed vaginally or abdominally via open or laparoscopic method. To decide the route of approach, one must factor in the presence of other gynecological conditions or disease, uterine size, the presence and size of uterine fibroids, the mobility and descent of the uterus, the size and shape of the vagina, and history of previous surgery. This table compares the advantages and disadvantages between myomectomy and hysterectomy. Hysterectomy should only be considered if other treatment options have failed. There is a wish for amenorrhea, the patient no longer wishes to retain her uterus and fertility, or by patient's request. When counseling a patient, it is important to give them all these information to help them make an informed decision about which procedure is most suitable for them. The advantages of a hysterectomy include no risk of further recurrence compared to myomectomy, with a high patient satisfaction. However, future fertility is not possible, and the surgery is generally longer and more complicated than a myomectomy, resulting in a higher risk of complications. The following table compares the advantages and disadvantages between the various approaches for myomectomy. In general, laparoscopic myomectomy has a more rapid recovery with shorter hospitalization stay, less post-operative pain, and less post-operative adhesions compared to the open approach. However, laparoscopic surgery is technically more demanding and special training is required. Laparoscopic myomectomy is recommended for gynecologists who are good at laparoscopic suturing. The size of the myoma selected for laparoscopic approach should not be greater than 10 cm in diameter. Hysteroscopic resection is recommended for submucosal myomas under 4 cm in diameter. Its main advantage is that it can be done as a day surgery procedure with no abdominal incisions. An alternative to surgery is uterine artery embolization, which involves complete occlusion of both uterine arteries with particulate emboli. This serves to decrease fibroid size by 40 to 70%, with improvement of symptoms in 80 to 90% of patients at 1 year. Major surgery is avoided with minimal blood loss, a shorter hospital stay, and quicker return to daily activities. On future fertility, miscarriage rates is higher than in patients without fibroids, but there are several case series documenting successful pregnancies post-embolization. Magnetic resonance image-guided ultrasound ablation of uterine fibroids is a non-invasive technique where fibroids are located under MRI guidance, and ultrasound MG is then used to ablate the fibroid. This is an option for patients who wish to avoid surgery. This is the end of the VAP. Further reading references are as stated.